Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule. I got Mark and Drew here with me again, and we're going to talk a little bit about knee OA today. So let's go ahead and jump right in. We're going to try and get a pretty broad perspective on it. So Drew, just give us a little start off. What does the clinical presentation of this patient look like?
Yeah, so I think it can vary quite a bit by patient, but the typical one, they're obviously going to be older adult. They're going to be usually over the age of 60. But I would say the one that I see most common in clinical practice for me is the person who has maybe not taken care of themselves into their 50s, into 60s, and then they're suddenly like, I want to be able to play with my grandkids, do this, enjoy retirement, travel, and they start to get active and suddenly they start to have the knee pain. They look at an image and the doc says, hey, you have knee OA. You need a replacement, or this is why it's bone on bone, right? That's typically the presentation.
Yeah, I think it's interesting, and I appreciate you bringing it up. That there's something that happened, right? I mean, we know that bone on bone did not just happen this week, right? I mean, we're talking about years upon years, and so is it that inactive person that something happened, they try to change the activity? Is it the active person that likewise is not calming down enough? So we as we get a lot in PT, we probably get some more chronic things that show up with acute irritation. And we know that our society still wants to go after treatments that are more going after structural bases than maybe something different here. So yeah, something brought them in that we're looking at. So Mark, what does day one focus look like as you're working with this patient?
Well, I think you guys hit on it a little bit, but education is probably the most powerful tool that we can provide to them early on. Now, that's not the only thing that you're going to do. A lot of times they have mobility restrictions and difficulty just moving around daily life. So those are things that you absolutely want to address. It might mean that you do some manual therapy. It might be some mobility exercises. I typically use the framework of mobility before stability. And so getting them moving a little bit better and then start loading them up a little bit. It could be later in the session or it could, wait a little bit, but both of those things do need to happen. But as far as the education goes, I mean, you guys talked a little bit about imaging findings like that didn't just happen overnight. It's accumulation of time and then, certain activity just triggered something that was already there essentially. And then also looking at this as symptomatic arthritic conditions are a metabolic condition, meaning that what you are eating and how you are sleeping and just essentially lifestyle behaviors are the things that are setting you up to have symptomatic arthritic conditions. And so, that's not something that I'm going into a tremendous depth day one because, if I do, they're probably not going to come back. But it is something where I'm going to plant the seed early on. Hey, there's this research that suggests, that, dietary fiber can help with symptomatic knee arthritis. Do you know how much fiber you get in a day? And just start to have them think about these things, start to actually look at what they're eating, what they're putting in their body. And then, that way I can follow up on it at future sessions.
I think the key part there that you said, Mark, is as you're bringing these things up, not focusing on the image and more on the symptomatic presentation of it. And if they can switch their thinking from this is what my picture is and I am my picture to, well, it's a picture. What does that mean? Then you gotta like that's the key part is laying the groundwork for that conversation.
Definitely.
Yeah, I think those are all so important because I mean, the reality is this patient is going to have been to a primary care provider who told them you need to diet and exercise, right? I mean, they're telling them that. I mean, there's plenty of times they've been told that. And so, we're looking at how do we translate that to something that turns a light bulb on for these patients, right? I think, as you said, there can be looking at bits and pieces of it. And, for me, it's typically, I think of this more in my chronic pain crew, but I'm looking at diet, looking at sleep, looking at stress, and looking at movement, and just kind of those four buckets and breaking them down and really trying to figure out between them, hey, of these four, which is one that you recognize we really can work on a little bit? Because I think everybody knows that they need to work on some of these things, but one of our superpowers is finding a strategy to get them from this level to this level because they just have trouble seeing that bridge. And so it may be the diet and the fiber needs to be where you're plugging away. It may be, hey, you're sleeping 3 hours a night. You probably need to attack that first year. And so, our job day one may be to help them see that, yeah, it could be your bone on bone, but it also could be that you're not getting sleep, and that's going to help key into this. So I think one of the big things that day one we have to start with is really figuring out and helping them to see how can they create an environment for their body to heal themselves. Because whether or not they go on to get knee replacement or whatever have you, these things are going to matter. And so I think that's where we possess the time and the ability to manage these things better than a lot of other professions do. And I think it's big to use that time to find out what it is an area that they can be able to go after first. So kind of working through day one. We've had the conversation. We've really targeted the educational component of it here, and this can depend on acuity a lot of times. I know, but where are you guys focusing on your progression here? Like what kind of things are you looking to do after you've really targeted on the educational component? Now, whether it's manual therapy, whether it's exercise. Let me hear some pearls from the fellows here around how you're going to attack this arthritic issue here. Mark, you got something?
Well, like I said, I typically would start if they have range of motion restrictions. I'm probably going to start addressing that in some way, even if it's just decreasing pain so they can actually move better, or if there's actually a joint restriction, trying to target that. And then, I talked about mobility before, stability. I'm always going to do something after that. It may be mobility exercise, but I'd like to start to introduce some closed chain strengthening, some loading, and particularly with knee OA, I would probably start with shallow depths just so they're not getting as much, I guess, compressive force through the knee joint there initially, just to start getting them moving and everything. And then obviously over time working into more and more depth.
Nice. Anything to add there, Drew?
Nothing substantial. I concur. I like, especially with these patients, usually we can start to make some sort of a change with some manual therapy. And that does, I think, two things. One, helps them to move a little bit more. And especially if it's the patient who, gets flared up if they're starting to walk or they're trying to start a walking program, lose weight, get healthier. If we can start to make those little changes to make that easier, that's going to help again with that lifestyle change, and it also help with that buy-in a little bit more. The biggest thing that I would say for most of these patients, you can be a lot more aggressive with like an extension deficit versus flexion, especially depending on the progression of it. Or it's pretty advanced, flexion limitations are definitely harder to progress quickly than extension ones in my experience. So I think it's probably maybe even a little more functional is trying to get them walking if they can hit extension a little bit easier as well. But that's usually what I'm looking at first for the range of motion. And if you're going to be using manual therapy for this condition, as I'm extension, then flexion as tolerated. Usually it's going to have some sort of a gapping instead of just a compressive force as well. So like wedging your forearm in to if you can, or some sort of a distraction usually feels good for these patients versus just trying to do a
Yeah.
straight physiological compression flexion thing.
All right, 15 seconds each. What's one thing you're sending these patients home with that they can be doing in between sessions?
I think getting them moving in a walking program or some sort of activity that they can handle without getting a flare up is key. Whether that be getting them to a bike instead of a walking weight bearing program, but ultimately I want them to get moving and active and gradually progress. And that's a big piece of what I want them to be able to do.
I like that. And I'll say that in addition to that, I'll give them some sort of technique that they can use to help modulate their symptoms. Hopefully, it matches well with the manual therapy that I gave them, but I'm going to give them something that they can do. Okay, my symptoms are a little irritated. I know I can do this and it'll take care of it or calm it down some.
Symptom modulation and getting them moving. Like it, guys. All right, until next time.